Ophthalmology and KSOS. This is the first online meeting as a part of KJO Research Proficiency Initiative. So I would like to speak a bit about this innovative project, Kerala Journal of Ophthalmology Research Proficiency Initiative. So basically, this is a kind of um, venture we have started to support and to mentor research aptitude among our KSOS members. So we all know that we are practicing clinicians. We have a lot of interesting cases, but that gap between what we see and practice and publication is sometimes very, very long. And sometimes we do not make it to a publication. So one of the reasons, apart from our so-called interest or uh, the kind of busy practice we have. Another one important reason is that many times, many of us do not know actually the ways and means to get something published. So we understand that there is a lot of support and mentorship to be given in this regard. So KJO editorial board has come up with this initiative, and this because the case reports are the most very primary kind of publications which any practitioner can actually aspire for. We thought we'll start with case reports and case series. So this session is titled "How to Write a Case Report," and from there we aspire to go to other kinds of study designs or literature search or statistics kind. So for our first premier project, we have got a outstanding faculty, Dr. Ramesh Venkatesh from Narayan Netralaya, Bangalore. And I thank sir for accepting our invitation and being here to share your knowledge and wisdom. And our moderator today is Dr. Biju Raju. He's our on KSOS member, and sir is also a senior retina consultant from NST Raju Eye Hospital, Kochi. Welcome, Dr. Biju, to the meeting.
Thank you.
And
thank you.
Yeah. And I'm so thankful to all of you who have actually made time and have been present here. I think we have almost 51 participants. I'm sure more people are to join. And I would also like to thank KJO editor, Dr. Manju M, for supporting me in arranging this meeting. Thank you, Manju. Dr. Manju will be thank you, Manju. Dr. Manju will be introducing the speakers and the moderator. And welcome all KSOS members to this program. Please do make use of it. We hope to have a good discussion. Thank you. Over to you, Manju.
Good evening, all. Let me introduce our mentor today. Dr. Ramesh Venkatesh is a senior consultant in vitreoretina at Narayana Netralaya, Bangalore, with over 15 years of experience. A fellowship-trained specialist from Shankaran Netralaya, Chennai. He is an expert in managing diabetic retinopathy, vascular occlusions, ARMD, and performing MIVS for retinal detachment and complex retinal pathologies. With more than 250 peer-reviewed publications, his research is mainly on MACTEL, CRAO, CSCR, and role of retinal imaging in chorioretinal diseases, integrating clinical care, research, and education. Welcome to you, sir. And our moderator today is our Biju Raju, sir. Sir is a vitreoretinal surgeon at NST Raju Eye Hospital, Kochi. He has over 30 publications in peer-reviewed journals. His interests are on ophthalmic imaging, smartphone fundus documentation, and surgical innovations. He is one of the first surgeons in India to introduce MIVS and published the country's first report in 2005. Now, we will begin our session. Over to you, Dr. Ramesh Venkatesh, sir. Thank you.
First of all, I am extremely thankful to the KSOS for giving me this opportunity and the Kerala Journal of Ophthalmology. It was way back in 2011, 2012 when the Kerala Journal of Ophthalmology was considered to be one of the premier ophthalmic journals at that time itself, when none of the state journals were even able to have some kind of relevance. Actually, Kerala Journal of Ophthalmology had already reached a position where they had been indexed, and there were people who were actually telling us that we need to submit papers for Kerala Journal of Ophthalmology. And it's very good to see you all being indexed in DOAJ already, and that's a big achievement. So thank you so much. And I really want to thank Dr. Sanita Satyan for giving me this opportunity to be a part of KJO and KSOS. And Dr. Biju Raju, thank you so much as well. It's a pleasure to interact with you. So what I'll be doing is I'll be sharing my slides first. So are the slides visible?
Yes, they are.
Okay. So this is a very interesting topic which has been given to me. If I remember in 2011, when I was a research cum clinical fellow from Shankar Nethralaya, and I was about to finish my fellowship in March 2011. I did not have a single publication at that time, and I was so stressed because I was the so-called research fellow, and I had to at least have one publication when I was exiting out from Shankar Nethralaya at that time. From there, if I could reach 250 plus publications, I think anyone can do that. And what I have learned in these last 14 to 15 years is that there is definitely a process which, if we follow properly, I think we will be able to get as many publications in many of the international and national journals of globally and at the national level as well. So I've been interested with this topic on how to write a case report. And to be very frank, a case report is a challenge. And it's because you want to express what you have seen in a patient so that the reviewer understands it in the way you want him to understand. And so that once the reviewer's thought process and the clinician's thought process align with each other, that is the only time when case reports usually get accepted. So I will start this entire session with a small case, and I will show something which I have seen in the clinic. It's an 84-year-old female diagnosed with neovascular AMD, and she complains of right eye decreased vision since the past 1 week. And she has been treated with 5 intravitreal anti-VEGF agents, which is given at a dose of 6 milligram in 0.05 ml. So you have a choice to choose what drug I'm talking about. And the last treated 3 weeks back. So the last last of the 5th injection was given 3 weeks back. Now let's look at this clinical presentation, and this is exactly what I saw in the on clinical examination. If you look at the slit lamp photograph, it clearly shows the diffuse keratic precipitates which is spread all across the cornea. When you look at the retina, you could see that the disc is hazily seen, but the media is very, very hazy. And when you do an ultrasound, you realize that there is moderate to severe amount of echoes, which is suggestive that there is some amount of inflammation which is involving the vitreous cavity as well. So here we have a patient who's being treated with anti-VEGF agent for a neovascular AMD. And what we realize is that he's presenting to us 3 weeks after the injection has been given. The injection has been a newer anti-VEGF molecule, already treated previously with 4 injections and not having any problem. But it's only after the 5th injection that he presented to us with large diffuse keratic precipitates and dense vitritis. Now, when you look and sit in the clinic, you probably believe, oh, this is something which we are noticing probably for the first time, an intraocular inflammation with a newer anti-VEGF agent. And but it doesn't look like an infective endophthalmitis, but it definitely requires consideration and it needs more proper workup. So when you are sitting in the clinic, and this is exactly what I think, is this case publishable or not? What makes this case extremely interesting? And should we write this up? These are the 3 questions which always enters when we see something very unusual in the clinical practice, where we want to know whether it's something which is worth publishing, telling our peers what we came across in the clinic, whether the case is really interesting, or should we write it up or not. So what we will do in this next 35 to 40 minutes is let's try and convert this case into a possible publication. And that is the entire essence of my talk, where this session I'm going to talk about how to write about a case report. Now, why this session actually matters is basically because we in India and in Kerala or any other state, we have a very high level of clinical exposure. We see so many patients in a clinic. We usually see on an average of 40 to 50 patients in a day. Let it be an ophthalmologist who is in a tier 1 city, or as in a tier 3 city, the number of patients which we see in a day is very high. Now, many of these interesting cases which we see in the clinic, they usually go unpublished. We don't even know that they are worth publishing, and a lot of information is not being shared with our peers as well. And always understand this, that publication is equivalent of documentation of clinical wisdom. So if you have been treating a patient in the right way, and it is basically writing up the treatment in a publishable manner so that it can be shared with all your fellow ophthalmologists and the fellow colleagues. So always remember this one thought, that unpublished cases are lost knowledge. If you don't publish, the knowledge which you have gathered or the experience which you have gathered by treating or seeing those kind of cases is usually wasted, and it cannot be shared anymore. So unpublished cases are lost knowledge, and we don't want to lose knowledge at this level. Now let's understand one very important concept. Dr. Sanita spoke that we are clinicians, and therefore it is very important that we do the right kind of research when we are sitting in the clinic and seeing patients. Now, a lot of clinicians always think that research is basically experimental research. We need to do something big, like something like in a lab-based format, where you want to work with a lot of chemicals, or you want to do some big clinical trials. You want to do some randomized clinical trials or RCTs, and which requires a lot of funding and infrastructure. That is what most of the clinicians think research is. But if you look in reality, there is a separate group of people or clinical research which deals only with case reports and case series, observational studies, or interventional studies, and real world evidence. And it is this real world evidence which is very important to all our fellow clinicians, who can actually understand what they usually encounter in the clinics. So as clinicians, our strength lies in clinical research and not in experimental research. And therefore, we need to primarily focus on case reports and case series, and even observations, which we commonly see in our patients. Now, there is always a thought which comes to our mind: when is a case publishable? Is every case a publishable material? So probably the answer is yes, and probably the answer is no. But what I do is that there is something which I work on, is known as the publishability filter, and there is a 6-point filter which I try to use in my understanding, to see whether a particular case report or a particular case which I see in the clinic is worth publication in one of the international or national journals of globally. So the first filter which I try to use is whether the case which we see in the clinic, is it a rare one? Is it a rare entity or not? Does it provide a strong teaching value, so that once the reader reads it, it should provide a strong teaching value so that he can apply that in a very easily readable format in the clinic? Is it an unusual presentation of a commonly encountered disease? Are we presenting a new imaging feature or a novel imaging feature or not? Are we providing a new unique management to this particular case? And lastly, did we encounter some unexpected complications or not? So this is a filter which I try to pass through. So if you think that there is a publishable funnel, okay, you put all these 6 values, or you put all these 6 points into the funnel. And if all of them pass through that funnel, that means the case report is not a publishable material. But if there is something which you identify on that in that funnel, and you probably see that the funnel retains one of these 6 factors, then you know that it is worth publishing. So those 6 factors are rarity, strong teaching value, unusual presentation, a novel imaging feature, unique management, and unexpected complications. Now, in our case, there was something which was quite unique. One is the rarity of intraocular inflammation being seen with one of the newer or the second generation anti-VEGF agents. Yes, definitely it gave us not a frequently reported intraocular complication which we come across with intravitreal anti-VEGF agents. It presented to us with an unusual presentation. We don't come across cases of intraocular inflammation presenting to us with large diffuse keratic precipitates and dense vitritis. It also presented to us an unexpected complication. So if you look at the publishability filter, we had 3 points, which actually tells us why this particular case is probably of a publishable material. The minute you identify that your case is of a publishable material, the next question which you need to ask is whether this case is interesting to me and or whether the case is just is interesting to the literature. So when you want to publish a case, it has to be interesting to the literature and not just interesting to me. So whenever you come across a case which seems interesting to me, you need to discuss those cases in the department meeting. So we have a lot of medical colleges who have classes being taken in the afternoon. So present these unusual cases in the departmental meetings. Present these cases in smaller meetings, CMEs, case discussion platforms. A lot of the state have got case discussion platforms. We have the Bangalore Retina Club where we present such kind of interesting cases, and definitely don't hesitate to present these cases in state conferences. So this is something where you want a case which is rare, which is of a publishable material to be presented in departmental meetings, and you want to see whether that particular case is just interesting to you or whether it is interesting to the overall literature and to the community as well. And you would always realize that when your peers, they react strongly, you know that the case is already publishable. It's a very likely publishable kind of a case. So this is something which is an indirect way of trying to tell whether the case is worth working on or not. So this is something which I usually do. I ask my fellows or my postgraduate students to present such unusual cases in one of these big meetings, and we look at what the seniors or the experienced clinicians have to offer. Always remember one thing, that there is no match to experience, and this is where a lot of ophthalmologists who are experienced, they usually discuss such kind of scenarios in these meetings, and therefore you come to know, okay, how their case presented to them, and how did they treat those cases in the best interest of the patient. So before you start writing a case, you should always look at the literature search. And this is a most important aspect where you want to look into. You want to spend sufficient amount of time where you want to look at what has already been published. Now, when we look at the literature search, I use primarily PubMed and Google Scholar, but there are other reference platforms which are available, like the Scopus and the Web of Science, where you can see whether similar reports have been published or not, and what does the literature actually offer us, and how our case would probably be different than what has already been published in the literature. Now, let's understand how the literature search works. Now, for my particular case, when I wanted to look at intraocular inflammation with anti-VEGFs, you would realize that there are 202 results. So that is really something which you would say, oh, there are a lot of papers which have already published on the intraocular inflammation with anti-VEGF agents. The next minute when I see, okay, what is the number of papers or previous publications which talks about ocular inflammation with intravitreal anti-VEGF, and how many of these have actually been published from our country, India, you would realize that 202 actually comes down to 15. And you would realize that, oh, there are 15 papers which have spoken about anti-VEGF safety, intraocular complications, and intraocular inflammation. And therefore, there is something which we know that, okay, not globally, but at least at the national level, this case could have some relevance. The minute you change your filters and try to see, okay, how many of these intraocular inflammations actually presented or has been reported with a presentation of keratic precipitates, that number further falls down to 2. And when you look at the number of papers of intraocular inflammation with anti-VEGFs coming out from India and presenting with keratic precipitates, you realize that there are no papers which are presenting to no papers which have already been published in this particular keratic precipitates presentation. So now you realize that the most important thing from our publication or our case is the importance or the relevance of the patients presenting with diffuse keratic precipitates, those large keratic precipitates following an intraocular injection with anti-VEGF therapy, presenting to you with dense vitritis, but actually at 3 weeks post the injection. So this is your big take-home point when you do a good literature search. Now, once you've done the literature search, always ask whether what is new, what am I offering new to with this case report, and am I adding anything relevant to the literature or not? And these are two important questions which you need to keep asking yourself to see whether your case is going to be publishable, whether it makes any relevance to the clinical fraternity or not. So when you go back and look at our case itself, we would like to ask the question, what's so unique about this case? And you would realize that intraocular inflammation with newer anti-VEGF agents are not frequently reported from India. And that is something when we looked at the literature search, we realized that there are not many papers or publications which talk about intraocular inflammations with anti-VEGF agents, especially the second generation anti-VEGF agents. The real world evidence does not talk about the management outcomes from India. There are not many papers which talks about the real world outcomes from India. The case probably also teaches the clinician regarding the rare intraocular inflammation presentation, the exclusion of the infection and the individualized therapy. And it also discusses the management strategies, the outcomes, and what should be the treatment plan if there is a reactivation of a CNVM in such a patient who presented to you with intraocular inflammation. So once you know what's the uniqueness about your case, then it's the time to decide whether you want to write the report right now, whether you want to wait for more follow-up visits and produce a more longitudinal kind of a presentation where you want to look at the pre and the post-treatment outcomes, and whether you want to take a decision, okay, we don't have much to talk about or publish in this particular case, and therefore it's not worth publishing. So this is the most important thing which you need to take. These decisions need to be taken promptly so that you don't waste a lot of time and energy in thinking whether it's worth writing or whether it's not worth writing a particular case report. Now, let's talk about writing a case report. And this is where the initial few minutes I actually spent on deciding whether a particular case is publishable or not publishable. And now once we have decided that, okay, the case is of a certain value where we feel that it's a publishable one, the idea is to write that particular case report immediately. So there are different components of a case report. If you look at a case report from any of the journals, you will realize that there are 6 components which are present in a case report. The first is the introduction. Then you realize that there is a case description or the case presentation, then the discussion, then you have the conclusion, and then you talk about the references which you have cited in your paper, and then you end up the paper with figures and captions to those figures. These are the most important components of a case report. But the minute you start writing, you don't know where to start from. Whether should I start from the introduction? Should I start writing the case description first? Should I look at the references and start including the references? Or should I start writing the discussion first and then think about the case description later? So this is the question which we frequently encounter. In fact, as young ophthalmologists, we always have this problem that how do I start writing my manuscript? From which section should I write the introduction, or from the case description, or from the description itself? And over a period of the last 15 years, I realized that the best way to write a manuscript is with this formula. So if you look at these 6 components, this is how I write the manuscript. I start with the case description first. And I'll give you reasons why we do with the case description first. And following that, I take the figures and captions. Then I write the introduction, the discussion, the conclusion, And then I include the references which I'm already planning to include in the paper, in the manuscript, and also include in the reference bibliography. So these are the ways by which I actually start writing my manuscript. And I'll tell you one thing, that over a period of years, I've realized that this is the most smoothest way of writing your manuscript. And I'll explain you in each of these sections why I prefer to follow this particular pattern. Now, the question which you would probably be thinking is that why is Dr. Ramesh asking to write the case description first, when the first component of the manuscript is actually the introduction, which is there in the manuscript? And the answer is because the case description is basically a chronological sequence of events which we see in the clinic. It's just a chronological sequence of events. It is factual. You don't have to look into references. It is just what the patient presents to you in the clinic, and it does not require any interpretation. And that is where you want to initiate the process as early as possible, create the momentum. And this is where the easiest way to write the case report is starting from the case description. Now, there is a checklist which I have formulated over a period of time about what should be the checklist when I'm writing a case description. Many a times you would realize that the reviewers say that, okay, you have not included this particular point in the case description. You have not included a particular point A in the case description. So what I realize is I always tell my fellows that when you are writing a case description, you need to have these 10 particular pointers. The first pointer is the demography. You want to talk about the age, the sex, the ethnic origin of the patient. You want to tell where the patient is coming from. Then you want to tell about the systemic status. What is the general health of the patient? Is the patient a diabetic, a hypertensive, an immunosuppressed, debilitated patient? What does the patient present to you with in the clinic? Does he present to you with visual symptoms? If the visual symptoms are present, does he present to you with blurring or diminution of vision? Many a times I have realized that people make this simple mistake that even when a patient presents to you with a visual acuity of 6/9, okay, they write that there is a decrease or there is a sudden diminution of vision. You need to understand that diminution of vision means loss of visual acuity. Now, when a patient presents to you with 6/6 and 6/9, there is not significant loss of visual acuity, but what does the patient encounter is the visual symptoms. They could be as simple as a loss of visual field in cases of retinal detachments, or a central scotoma in patients with CSCR. So those are or metamorphopsia in a patient with epiretinal membrane. So these are the visual symptoms the patient presents to you with. And therefore, it's very important to understand the basic differentiation between blurring of vision and diminution of vision. Then you talk about the eye which is affected and the duration of the symptoms. Following which, you need to mention about the past history. Did the patient experience any recurrent previous episodes? What was the previous treatment taken? So if you look at our case, the previous treatment which the patient had taken was 4 intravitreal injections of anti-VEGF in the clinic, and did not encounter any previous episode. So he was presenting to us for the first time only after the 5th intravitreal anti-VEGF injection. Then the most important thing comes when you talk about the ocular examination. And when you talk about ocular examination, you need to mention about the visual acuity. The best preferred format is the Snellen's visual acuity, the intraocular pressure, the lens status, the anterior and the dilated fundus examination. These are the 5 components which has to be mentioned in the ocular examination. The possible clinical diagnosis, which you realize just by looking at the visual symptoms, and the most likely differential diagnosis. Then you look at the relevant ocular and systemic investigations, which could help you in funneling down the right clinical diagnosis or confirming your clinical diagnosis. Come up with the right clinical diagnosis, rule out the differential diagnosis, provide a treatment plan, look at the follow-ups and the outcomes. And the most important thing, always mention in the last line of the case description that the patient's consent has been taken for the utilization of the clinical information and the images for publication purpose. And many a times you would realize that most of the journals actually return your case report because you don't take a patient consent form. This is unlike the larger studies, the control case control or the cohort studies where you require ethical clearance. Here you don't require ethical clearance, but what is important is the patient consent for the utilization of the clinical information and the images for a publication purpose. Now, in our case, this is what we realized using those 10 pointers from the case description. And you would realize that when I write this case description, I have written that it's an 84-year-old female. She's well controlled with diabetes and hypertension, complaining of diminution of vision in the 1 week, treated with anti-VEGF agents. And on ocular examination, this is what we found. We found diffuse KPs, dense vitritis on fundus examination. We gave a possible clinical diagnosis of post-injection intraocular inflammation. We also thought about relevant differential diagnosis like infective endophthalmitis. We ruled out infective endophthalmitis by doing a microbiological sampling of the ocular fluid and the systemic fluids. We treated the patient with systemic and topical steroids and performed an optical vitrectomy, which was more for the media clearance. We gave a final outcome of vision improving to 6/6 at 4 weeks, and we told that the patient did not encounter any recurrence of intraocular inflammation or CNVM reactivation. And we end this case description section stating that the patient consent for the publication and the utilization of the images has been obtained. And this is probably the most important thing when we talk about the case description. Now, the important thing in a case report is also utilizing the right and relevant images. Now, the images, they should tell the case story. It should not exactly be a repetition of what you have written in the case description. It should be a story where it's by itself, where just by looking at the images, you would realize, okay, what are we dealing with? They should be of high quality. Most of the journals prefer more than 300 DPI, and they should be relevant. They should be absolutely relevant to the case which you are describing. You should have proper arrows and annotations, and you should, the case images, they should not be cluttered. Now look at this sample image which I'm giving you, and you would realize that in this particular image, I have almost around 11 to 12 panel images, and all these panel images, they give information of different imaging modalities, and they are totally cluttered. Now this is a particularly no-no, which most of the journals don't accept. They don't want so many images. They want the relevant images to be included in your manuscript. So when you try to look at the previous image, which I showed you, it realized that that image is overloaded both for the reviewer and the reader with a lot of irrelevant information. The panel images should ideally be between 4 to 6 panel images within a complete image. And for the follow-ups, always keep the image type the same. That means if you're showing OCT, then all the follow-ups should have OCT passing through the same region of interest. So this is the image which I worked upon for my particular case, where I showed a slit lamp image, which was showing the dense diffuse KPs, which is spread all across the cornea. I showed the fundus image to tell them that how badly the retina was visible. The media was very hazy. And then the ultrasound image to show that there was the P-scan, which was showing dense vitritis at presentation, and therefore the view was very hazy. But when you look at the follow-up images, I just kept the 2 follow-up images. One was the color fundus photograph at different time points of the patient treatment. And then I kept the slit lamp photographs both in the dilated and the undilated states to show how the keratic precipitates were resolving over a period of time. Now, I did not include the B scans because the B scan in the follow-up image does not provide any valuable information because the fundus photographs are always being shown and they were giving you how the vitritis is resolving over a period of time. Now comes the third important section in your case report, and that is writing the introduction to your case. The introduction is one of the most important things which I feel as a reviewer or as an author or as a reader as well. It answers the most important question. Why should I read this case? Is there a particular reason why the author is planning to publish this case? And if it is he giving me sufficient reasons on why I should go ahead and read this case and spend a lot of time in analyzing and understanding this case? So the introduction must answer three important questions, and that is what I feel is the three Qs which the introduction must answer. The introduction must answer what is already known about this condition. Is anti-VEGF the mainstay of the treatment? Has intraocular inflammations following an anti-VEGF therapy already been reported? Has this condition been reported previously or not? Why is this situation unusual? We should also try and understand that why is our particular case, presentation unusual? Is it because of the rarity, the unusual presentation, or the unexpected complication which we encountered? What gap exists when you look at the current literature? So the introduction must always address these three questions. It must be brief and should not include more than 3 to 5 references in the introduction section. So when you go back to our case, we answered these three questions. We answered these three Qs. We said that, okay, neovascular AMD, the anti-VEGF is the mainstay of treatment, and intraocular inflammations with anti-VEGF agents have already been reported. What's unusual for our case is that intraocular inflammations with newer anti-VEGF agents are extremely rare, and there is a very rare clinical presentation or an unusual clinical presentation with this diffuse keratic precipitates. What is the existing gap? If you look at this part, we realize that there are no reports from our region. We don't have many reports of intraocular inflammation secondary to the newer anti-VEGF agents coming from India. It talks about the real world evidence. It teaches the clinician about how to recognize these intraocular inflammations early. It helps them to exclude the infection and to individualize the therapy. So these were the three important aspects or the questions which we answered in the introductory portion of our report, which probably will make the reviewer think further and, okay, let's go further and read what the case actually describes. Then I write the discussion portion to the case. And this is again a very, very important section. While the introduction was trying to tell the readers why they should read the case, the discussion is where the intellectual component of your case starts coming out. So the discussion, basically, it converts the clinical presentation or the clinical information which we have provided into knowledge. And this is where most of the reviewers or the readers are looking forward to. They want to see a very strong discussion. They want to learn more from the particular case so that they can apply it at a bigger level. A case description is basically a factual details. Like I said, it just gives you the factual details without in any interpretation. Whereas the discussion requires a lot of analysis, it requires a lot of interpretation, and is therefore the intellectual component of your manuscript. Now let's look at the discussion section which I wrote for my particular case. And the discussion basically should tell us what is the novelty, how is the novelty being proven in your particular case. It tells us how good you have done a good review of literature. How much have you understood the review of literature? It tells us, it provides the why behind the what. It provides us with new mechanisms to explain the clinical presentation which we commonly encounter. And the discussion establishes the clinical relevance. And this is why the discussion to your case is very, very important, because it tells you how to prove the novelty. It tells us whether you have done a good literature search or not. It provides the why. It tells the why behind the what which we see, and it establishes the clinical relevance. So when you want to write the discussion section of your manuscript, this is the 5-step structure which I commonly follow. The first structure is what is known, what is already known in the literature before. Is my manuscript or is my case adding anything new to the existing literature or not? Why is my case unique? Am I presenting something very unusual or rare that makes my case unique? Am I presenting some unexpected outcome? Am I presenting some unexpected management strategy? Why is my case so unique? That should be your second paragraph in the discussion section. Why this difference exists, and this is where I talk about the why behind the what, where you want to explain the difference which is seen, and you would probably give a theory or a reasoning for that difference, and that is what you need to mention, the why behind the what. Then what would the clinicians learn from my particular case? And that should be the fourth paragraph of your discussion section. And finally, you should also acknowledge a few limitations of your particular case report. Probably this is the one-off case which you commonly see. You probably need a larger series to explain the pathogenesis or the pathomechanism for that particular finding. And it is always good to acknowledge a few of limitations with your particular case. Now, when we look at this 5-step discussion, which I used in my case, the first case, section was the clear case framing. I clearly mentioned that this is a severe type of intraocular inflammation which is delayed in onset. It mimics infectious endophthalmitis. It establishes the core diagnostic dilemma which we see routinely in our clinical practice. We are worried sometimes of between exaggerated intraocular inflammation and infective endophthalmitis. And it links the clinical findings with the steroid response. It also tells us the positive response or the outcome which we got from our case when we started the patients just with the treatment with steroid therapy. The second thing which, the second paragraph which I spoke about was the literature integration. And when you do a strong literature search, we include cases of intraocular inflammation with anti-VEGF therapy, which has been reported previously. We look at the previous cases with milder and earlier onset, while our cases shows a more severe and delayed onset of presentation. Our case report talks about or demonstrates the literature review thoroughly, and it positions the case within the global and the Indian context. And that is what our case was actually trying to tell. It clearly defines novelty and differentiation. And when you look at the previous reports which have been published with intraocular inflammation, it tells you that our case has got a delayed presentation, dense vitritis, treated with systemic steroids and vitrectomy. The patient was treatment naive. It's not a patient who has been treated with previous anti-VEGF agents and now been switched to this particular molecule. This patient was on a loading dose and a fixed regimen. So that is also a very important point, and it is one of the rarest reports which have been reported from the Indian subcontinent. We also provide a scientific reasoning. We gave a reasoning regarding, okay, what could be the possible reasoning for or mechanism for this? It could be an immune-mediated etiology, a lymphocytic predominant cytology. We provide hypothesis for immune sensitization and use of we use cautious academic language so that we try to maintain the balance so that we always keep intraocular infection or infective endophthalmitis as the first thing which needs to be ruled out when a patient comes to you with this presentation. We also provide a strong clinical take-home message which could be very useful for our fellow clinicians. Now, when we look at the fifth component of our case report, we talk about the references. And there are a few common mistakes when we cite references and include them in our bibliography. We include too many references. We include a lot of references, just overload our manuscript, thinking that, okay, the reviewer would be very happy that we have looked into so many references. That's overloading. And we provide a lot of irrelevant and outdated references. We do not cite the landmark clinical studies. Like in our case, we probably want to study, we want to use the clinical trials like the Tenaya and the Lucent, the Hawk and the Harrier, which probably we usually don't try to cite, and we read the references or we cite the references without reading the full article. Many a times I have seen a lot of postgraduates or fellows or even young ophthalmologists just reading the conclusion of the abstract which is provided on the PubMed and try to make inferences from those abstract conclusions. The ideal number of references which we want to have for a case report would be for most of the journals between 8 to 10. This is the number of references which is sufficient. If you realize even IGO, it tells us that your number of references should be less than 10. The references should focus on landmark studies, similar case reports, recent reviews, relevant safety data, and you should always focus in having quality references rather than just having quantity of references. Now, we also need to, once you have created this structure where you have included all the 6 components, like I mentioned before, in this particular sequence, you should also be aware that why could this case report get rejected? And this is something which we need to understand, that most of the case reports, they may not have any novelty. They have a poor discussion, inadequate literature review, poor English, overstated claims, journal mismatch, no consent, planned plagiarism. These are the reasons why most of the case reports, they get this. Can I just pause for a minute? Just 1 minute. I just need to pause for 1 minute, please.
Sure, sir.
I'm so sorry for this interruption. Yeah. So the next important thing is once you know that why the case report could be rejected, you should always think about those 8 components which I spoke about to decide whether what would be the possible reason that if I submit this to a particular journal, there is a chance of rejection. So you should always anticipate that there is a possibility of rejection and what could be the possible reason. The most important reason which I see is not choosing the right journal. And this is where I want you all to understand and introduce to what is called as the match formula. Now, the match formula, M stands for something A, T, C, and H. And this is the 5 letters formula which I want to explain to you all. The first part or the first component of the match is matching the scope of the journal. You should always be aware that what is the scope of the journal, what kind of articles or papers does the journal actually accept, and therefore it is important to match the scope of the journal to which you are planning to submit. The second is the audience relevance. Now, a case report which talks about intraocular inflammation is relevant to definitely retina specialist, uvea specialist. You want even general ophthalmologists to know about it. So this is where you want your audience to be identified, and you should identify a journal where the audience is of a much larger one and not very specific only to a particular subspecialty. You need to know what is the type and the novelty level of your particular case report, whether it is very high novelty or whether it's a mid-level or whether it's a low level or not. You need to know what are the chances of acceptance if you submit to that particular journal. And this is very, very important. You don't want to submit a case report to JAMA Ophthalmology and within a couple of hours, you get a rejection saying that, okay, the case report is not worth it. Because you spend a lot of time writing the case report, aligning your report with the specifications which are provided by the journal, and you probably would realize that within a couple of hours, the rejection happens and you get very dejected with that response. And the last is the handling time and the practical factors. There are a lot of journals which take a very, very long time to handle the manuscripts. There are a number of journals which take almost a year or more to give a decision on your manuscript, and you don't want the journals which take such a long time. And this is where I feel the match formula is very, very important. The matching is for the scope of the journal, to the audience relevance, the type and the novelty level of your manuscript. They're looking at the chances of acceptance and handling time and the practical factors. Now, for my particular case, which we discussed over the last 30-35 minutes, I use the match formula. Now, when I try to scope match, journal match based on the scope of the journal, I realize that my case is very relevant to the retina and the uvea specialist. So I want to identify journals or uvea journals which accept case reports. And I would probably realize at a national or international level, I would look at journals which like retina cases and brief reports Ocular Inflammation and Immunology, Journal of Ocular Infection and Immunology, European Journal, Indian Journal of Ophthalmology. This is where I would look from my particular scope of the journal. So these are the journals which talk about retinal diseases, uveal pathologies, and they accept case reports as well. The second is where I want to look at the audience, and my audience are primarily retina specialists, whether they are surgical retina specialists or medical retina specialists, general ophthalmologists, uvea specialists who give injections, and therefore you want a journal which reaches a wider audience. When you look at the novelty and the type and the novelty level, you would realize that this is a mid-level case report, because it already talks about a complication which has been reported 202 times in PubMed itself. The case is relevant because of its Indian context, and therefore now you start looking at it from that I want to probably publish it to a reputable national journal, and therefore that is where I try to further funnel down on my choices of journals to IGO. Then I look at the chances of acceptance. We know that IGO case reports has got a higher percentage of acceptance. And then I look at the handling and the practicality factors, where I also look at the article processing fees, the color charges, which will be taken by the journal once the paper gets accepted. And looking at all these factors, I prefer to choose for my particular case or this particular case, something like an Indian Journal of Ophthalmology case reports, because that is the only place where IGO actually takes case reports. So I just want to conclude my talk by giving a strong take-home message. And the take-home message would be the 10 golden rules of writing a case report. And please understand this very attentively. I think these are the rules which we always want to follow, so that the chances of our manuscript on the case report gets accepted. So the first rule is observe carefully. So whenever you are sitting in the clinic, you see something very unusual, a patient presenting with a rare disease, a rare presentation, please document it very well, image it properly, and discuss it with your seniors, experienced clinicians in any of the meetings, any of the meetings or the forums where you get the opportunity. Ask yourself, ask the clinicians, ask the experienced seniors, is it truly new, or is it something which you all have seen before as well? Do a good literature search first. See what has already been reported in the literature. Define the core message. Identify what is the core message of your manuscript, whether it is the rarity of the presentation or the positive outcome which you had following the therapy, or the rarity in the Indian context itself. Identify what is the core message which you want to send across to your readers. Write the case first. That's the most easiest way to start writing the manuscript. So when I'm writing an original paper, I start with the methodology first. When I'm writing with the case reports, I'm writing the case description first. Keep the introduction short and sweet. Talk about the 3 Qs which I mentioned in the introduction section. The discussion must definitely add value to all the readers, the reviewers, and even the editors. Use strong images, use strong relevant images. Don't compromise on the quality of the images. Don't compromise on the imaging modality. Always take patient consent and write about it in the manuscript itself. And lastly, I just want to tell you all that once you have written a manuscript, don't fear about rejections. Just keep submitting them. There are so many journals. One of them will definitely get it, will accept it. So this is where I want to conclude and say that I want to wish you all the best for your research journeys. Okay, please follow these formulas which I have discussed in detail. Don't get feared about rejections. This is something that I even today get disappointed. But the only thing which I have learned over the period of the last 15 years is keep submitting, make the relevant changes, identify the reasons why the case report got rejected by the previous journal, and then resubmit it again till it gets accepted. Thank you very much.
Thank you, Dr. Ramesh, for such a wonderful talk. I mean, it was very focused and you gave all the pertinent points relevant to this topic. And I think the highlight was the way you built up the case, your own case report from, describing the clinical picture right from the time you saw the patient till how you zeroed in onto that journal that of your choice and which would be the matching journal. That was the highlight, a very practical way, rather than telling all the things about what a case report is. You've gone through that wonderful journey. It's like, hand holding through the all steps of case report description. I now open the floor, open the webinar for the discussion from our esteemed
Before you ask questions, I have to ask Dr. Sanita Satyan, because she's the editor of KJO. Would she accept my case report or not? Because the case is not published yet. So I just want to ask her that what do you think would be the deficiencies in this particular case, and what is the likelihood of this case getting...
There is a conflict of interest over here.
Yeah. Initially, sir, we would go through a proper
Ramesh,
review process.
I think there is a conflict of interest over here.
Hi, Matthew, sir. How are you?
Yes, sir. Please do submit your case report anyway, sir.
Yeah.
We'll go through a proper editorial process and get back to you at the earliest.
We have one question from Hasna. Dr. Hasna says, sir, does case report need ethics committee approval for publication?
So according to me, we don't take ethics committee approval for small case reports or case series. We don't take that. What you require, as I said, is the patient consent and the patient approval for utilizing the patient's clinical information and images. You don't require it for the case reports.
Yeah, I think that's very true. I think for a case report, you don't need an ethics committee approval. But if you're looking at a larger series and stuff like that, or a bigger study, population-based or otherwise clinical, you need an ethics committee approval. And that is what every journal is looking at. What is the clinical trial register number? That's an important thing, which requires an ethics committee's approval for the publication. My question to you, till we get more questions from the audience, is that, about documentation, which was a very important thing, and the way you presented the images, it's sometimes very difficult, right? You have taken so beautiful images, and sometimes to eliminate them out of your, collective, the top ones is a very difficult thing. But that's that apart. What kind of imaging modality you would look at? So I have got this question from several young authors or young aspiring authors, that what kind of will a journal accept photographs taken on a mobile phone?
If the quality of the images and the information which the images provide are acceptable, means they provide the right information which you are describing, or the finding which you want to describe, and that is visible, that is acceptable, then yes, it can be considered. So, but you need to edit those images, not in terms of the quality of the image, but at least in terms of cropping the image, so that this unwanted material which we have sometimes when we take from these mobile phones, that is excluded, so that you at least give the most important and the relevant information to the reviewers and the editors. Yes.
I think that's a very, very truthful answer that you said. I think from my experience, almost all the case reports that I have published, they're all mobile, captured with a mobile phone, not a very costly one, an ordinary Samsung phone. Another question, is it better to aim for a good journal first, so that even if it gets rejected, you get some good review points? That's from Dr. Nirmal. Your views on that?
So like I said, nowadays my focus has been to identify the right journal and not just keep waiting for the editors or the reviewers' comments. Okay, we probably know at this particular point what the reviewers are thinking. So it's like thinking from the opposite side and thinking what the reviewer could actually question me for, and try to address those points as early as in the manuscript itself, in the initial submission itself, and definitely aim for a good journal. You want the journals to be high impact, PubMed index, that is your first priority. Then you start lowering yourself to a weaker journals. Okay, so yes, definitely. But what I'm trying to tell you is that if you address all these points in the initial submission itself, the chances of rejections are much lower. And secondly, you should always aim for the right journal. I think that is the most important thing which you should focus on.
Yeah, that's another question on the same lines. Is there any way to find out the matching journal for a particular case report? I think you have given clear-cut description on that using that match point. In that, I just would like to just say an interesting thing. You said, chances of acceptance. On a Monday morning, I just sent a clinical image to, it's a long shot, but I thought I'll send it. I send it to JAMA. And in 2 days' time, the thing comes, if you are willing to revise this manuscript, we are willing to publish it. So it was a clinical image taken with just a smartphone. And in a couple of months' time, it got accepted. So sometimes, luck plays a role.
Yeah,
that also works.
Sir, I would add. I would like to add a few points from my short experience as an editor, and sir told to think from the other side. So one of the most important things which I come across as an editor is that they are exceptionally good cases, but the documentation is very, very poor in terms of image clarity, the kind of investigation. Sometimes certain case demands these investigations, but not all of them are there. That is one of the major reasons which we cannot accept a very important case. Second one would be the kind of writing, the language and the way it is expressed. That needs to be improved a lot, at least for some of the case reports which come to our side. And I have a question to ask actually. For some of the images, say for, especially I'm a squint surgeon, so some images when we have to keep the anonymity of the patient, we tend to blur certain parts of the face. So how was it? I know it is not a problem with retina or glaucoma or even cataract. So what are the usual conventions for, suppose you have to show a Marcus gun, Joe winking. I had a case like that, but how to ensure that patient confidentiality in the picture is maintained? What are the guidelines?
Ma'am, I don't know about too many squint images, but I'll give you an example of the fundus images which we see. So when you try to download an image from the Optomap or the Optos images which we have, the ultra wide field images, usually the patient's name, the organization where it has been done. Even for the visual fields, you realize that, okay, the patient's name, identity, etc., all starts coming up. So if that information can be cropped, I don't think there should be a problem in that. But many a times there is the placement of that information or the patient's identification factors is in a place where the most important or your relevant information of your case is actually getting mixed with. Okay, so in that case, what I do is I just keep a black patch. I just conceal that. I use a black patch. I use my paint software, keep a black patch and just conceal the patient identity information. And that still holds good, actually.
Okay. Another thing is, for example, in the radiological investigations, the kind of labeling of the relevant findings that I find it's all mixed up. That is also something which we should improve, I suppose. Thank you, sir.
So there are times when, like when I have to report a CT or an MRI or an X-ray, and I'm not the best person to talk about it, because the way the journal expects you to write the description for that particular image may not be the way you may not be the right person to write that description. In those cases, I definitely take the help of my colleagues or my friends who are specialists in that particular field, okay, and then probably include them as a co-author, or at least acknowledge their contributions in the manuscript itself. So this is something which I do. Regarding the English which you spoke about, means that sometimes we get articles rejected. If I have to tell you, and I'll be very frank to you, that there are a lot of articles which were getting rejected in my initial first 5 years post fellowship, and the reason was poor English. Okay. And we have to understand that we are not native English speaking people. That is something which probably the Westerners don't understand that. Okay. That we are not a native English speaking people. And there are a lot of papers which have got published. And there I can see Dr. Thomas asking me this question, use of AI in case writing. And that is probably one of the places where I probably think using using AI is particularly useful, because it helps you to write it in the way which the reviewer expects you to write, or an editor expects you to write. And that reduces the chance of rejection for one frivolous reason like poor English. And I feel that's the most frivolous reason that an editor actually can reject an article for. And probably this is an area where probably I think AI is very useful, where it helps you in paraphrasing the way you want to express yourself in the article. And that is where I feel AI is definitely useful for all of us.
Any more questions? Dr. Sanitha, can I add a couple of, he has covered everything, but some practical things on this thing, if you have
Sure,
time.
sir. Sure. If we have enough time, sir. Yeah,
All right.
please do.
The one thing I would say, when you talked about labeling the images, of course, there's the technical wordings and all that, like Dr. Ramesh had clearly said, you need to take the help of somebody who's an expert in that field, of course. But when you're labeling, one of the softwares that we ignore is PowerPoint. PowerPoint is one of the very powerful tool to put multi-panel images, to label the images, because it's easy, and that's something we are very used to working in. And it can generate each slide as when you export it, it can generate high quality TIFF or JPEG images. So when you are doing that, instead of going in for an image processing software, you can actually use PowerPoint to get this thing done and get the image out onto a TIFF or a JPEG. The other thing about thing is use a reference manager like Zotero, which is free, and you can add on the references easily and get that link to the document and get the bibliography at the end. So these are a few things that practical oriented, how you work on images and how you work on your references, because these are two things that many a time we get stuck on how to give our references in the right way. And if you say Indian Journal of Ophthalmology, Zotero plans the references in the style of Indian Journal of Ophthalmology, and it's very easy. It's freely available, and you can use it as you wish in your case report or any other article that you want. One question is, any preferred plagiarism checking tools to use?
I think Authenticate is the one which most of the journals use. Authenticate is the one which most of the journals use, but there are a lot of free available softwares. But the problem with those free softwares is they allow you to check plagiarism only for somewhere like 500 words, 1,000 words. Everyone has a limit. Okay, so you can't use. So, but Authenticate is the one which most of the bigger journals they use. That is something which I have seen. But now I think we don't think too much about plagiarism, because we grow bigger and bigger, we know what to convey to the readers and to the authors, to the reviewers and the editors. So plagiarism is not a bigger problem. Yeah, it is in the initial part of your publication journey where you may encounter such issues.
Yeah, Kerala Journal also uses Authenticate tool. And as for case reports, I think we are presenting the novelty of the case. So the kind of plagiarism we come across, I don't think that it is as to the level of an original article also.
You will realize that many a times plagiarism always, even if you check, the similarity checks which you get is almost in the range of around 5 to 10%. because plagiarism is what you try to call, write, my name is Ramesh.
Right.
The other person is also going to use my name is Dr. Sanita. So that my name is, that 3 words says that there is similarity. And that is where it will identify that there is similarity. So it is about the percentage of similarities which you come across. It should be usually be less than 15%. And if that is acceptable, that's not a problem.
What about AI generated tests? Sometimes text that you put, if it is AI generated, do the journals have an issue with that? Or we say that, we have used AI to prepare the manuscript. Do we have to mention that? Like
For
you said.
Case reports, I don't see many journals asking us whether you have used AI or not. Even if you have used AI, I usually express myself and say that, accept it, and say that, yes, I have used it for language correction. Okay, that is where I try to say that, yes, I use it, but not for creating or using statements directly from the AI. So I use it mainly for paraphrasing my sentences the way I want to communicate. Suppose I have used 50 words to communicate a particular thought. Okay. And the word limit which I have for a case report is very less. Then I use this software or use an AI tool to reduce the word limit so that I can still express it in the same manner with lesser number of words. So that is where I use it.
There's one more question from Dr. Sara. How much similarity plagiarism is accepted? I think
Like
plagiarism
I said,
is not accepted,
less than
but then
15%.
similarity.
Yeah,
Less
Kerala
than?
Journal, it is 20%. 20 to
20.
25% is okay, sir.
All right, thank you.
And nowadays, I think many of the journals are not accepting much case reports. So that is also a area of concern. So, but for any practitioner, the most important and the most easiest and feasible thing would be a case report. But also, as we do have some problems, especially for me, like to do a VEP in a case which is indicated. So that would be a very important investigation which is being missed out. So I think it is very important for a publishable case to have all the necessary investigations. There is no bailout on that. If you don't have it with your center, you should get it done from elsewhere.
So like Dr. Sanita, the way you said that, I totally agree. There are not many journals which accept case reports, but there are a few journals like BMJ case reports, which accept a lot of case reports. In terms of their acceptance rates of case reports are very, very high. The only thing is you need fellowships for that. You need to have paid logins. You need to have paid logins for that. And if there is a group who's willing to share, or if there's a Kerala Journal of Ophthalmology is willing to spend that much money and buy the fellowship, okay. Not Kerala Journal of Ophthalmology. I mean to say someone in
Some
the
other
group
group.
itself who wants 4 or 5 people all linked together and they can do it. Then I think it's really a chance. It's really good way of making your case reports publishable. That's the first point. The second point which I wanted to say is I lost track. Oh, shit. Okay, when I remember, I'll get back. Okay, I lost.
Yeah. And another one important thing is color
processing
pictures.
charges.
Yeah, that is we do not have for your information. KSOS does not charge the authors for color photos also.
Yeah, that's really nice because national journals like IGO, they charge quite a bit for color processing charges. Okay, and that's something where bigger institutions, they don't face problems, but when you have smaller practitioners or clinicians, or even private organizations, corporate people, means corporate hospitals, definitely that amount seems to be a lot, and therefore that could be one of the deterrents why you tend not to submit a case report also, because of the color processing charges. And when you look at journals like Retina Cases and Brief Reports, where your first color image is $500, now you start calculating 500 into 80 is, or 500 into 90 is 45,000 rupees. Then you say, nahi chahiye, I don't want to do anything about this case report. I will go for a lower end journal. So these are the challenges which we face usually when we start writing case reports. And like you said, many of the journals nowadays have stopped accepting case reports itself.
We have two questions. One is from Dr. Asna. We discussed that, but again, do paraphrasing using AI to leave AI watermarks, and can it lead to rejection?
So I don't see that happening. Means I don't see watermarks coming on the paraphrasing tool. Paraphrasing is you can just copy and paste also after the paraphrasing is done. So there is nothing to do with your the watermark. Or you can, even if you have a challenge, the maximum is you can retype exactly what has been written from the from the AI software.
I think what she meant was, the software watermarks. The software
I understood
detects.
that. I understood
so that
that.
way,
No. So it doesn't happen. Software watermarks don't come in that.
Like the type of words that it uses, not the human kind of connected words. It has its own way of writing a word. So that is detected by sometimes Grammarly detects it. Sometimes other software detect that this paragraph seems to be having about a large content of AI generated text. So that kind of prompts come. So that's what I think she's mentioning.
So to be very frank, I have not come across this means
Okay.
for myself. Okay, but yeah, I know that there are a lot of AI tools which actually will pick up whether the content is AI generated or not AI generated.
Okay. Then about the consent form, some of the journals have their own consent forms. So how do you do that? May I answer that, Dr. Ramesh?
Yeah, please go ahead, please.
I mentioned about the JAMA article. We had to get a consent form from their own website, that's downloaded. And I had to call the patient. The patient came, they read the whole thing, and then I made them read it. They were like, no problem, doctor, we'll do it. But then I made them read it because that's what the format was, or the protocol was. So, and then they signed it, and then we uploaded it. And JAMA accepts only that. Certain journals accept that. I think in Indian Journal of Ophthalmology, we just have to say that we have taken the consent. There is no particular form for that. So such journals is easier. But when you have journals like the high impact journals, they do require a special consent form, which are downloaded from their site, and then we take the consent and upload it in that particular web page that is required for the uploading of the consent.
So similar thing happens with BMJ case reports as well. So BMJ case reports also have their own separate consent form. And sometimes you feel that this is a bit of a headache, to be very frank. But but if you look at European journals, Indian Journal of Ophthalmology, I think a mention regarding the patient that you have taken the patient consent is sufficient enough for that particular journal. But like JAMA, BMJ case reports, they look at other things as well. They don't even like to mention the age of the patient. Some of the times, even age, a 48-year-old boy or a man is considered as revealing the identity of the patient. So in those cases, you need to word it very properly. You need to say a man in his late 40s, okay, of Asian origin. You have to be very careful because some of the journals, they require that okay, age, ethnicity and everything. Ethnicity sometimes needs to be mentioned. BMJ case reports demands that you need to mention the ethnicity of the patient.
One more question. Given a choice, would you like to submit your case report or any article, but case reports in this context, to a subscription journal or an open access journal? Which is your preferred target?
I have payment issues, so I will go for the subscription journal. Okay, but definitely I'll keep my funds more for bigger articles like original papers. Okay, where I will like to use my funds for this, but not for case reports, I think.
But then we have open access like IJOCR and
IJOCR, yeah.
Yeah, so those kind of things, I think that gives you a better, more wider readership.
Yes.
Visibility.
The readership and the visibility. That's why I said that for my particular case, I did not even think twice where I should submit it, because the only likelihood or the possible area where the article is likely to get accepted is in IGO because of the national interest which that case generates. So you need to be very specific. Sometimes you should not bother too much. Okay, IGO case reports is not PubMed index. Actually, to be very frank, it's not a PubMed index article. It's not a PubMed index journal. But sometimes you need to give away your craving for having PubMed index articles for the want of acceptance and reaching a larger audience. With the IGO case reports, you will definitely have a larger audience. Whereas if you probably would have published in BMJ case reports or in European journal, no one is bothered to know about an intravitreal anti-VEGF where they have already used it 4 years before we started using it. So they are not bothered about such kind of reports at all because they've already seen more number of inflammations than what we are seeing today. So that is the way I sometimes choose my journal also, that I don't be fixated for my need for having a PubMed indexed article.
That payment thing, even subscription journals have an open access, but the author needs to pay. Is that right? What I said? And that's a huge amount.
No, subscription again, it can, subscription is, it has nothing to do, means the author doesn't need to pay.
No, if you are planning to have your article as an open access in a subscription journal, then you need to pay the journal to make it open access.
That is huge amounts.
Huge amount. That's huge amount. Yeah. So that's the next question is
$2,500 and above.
The next question is based on that only from Dr. Avangshi. Sir, most of the articles in PubMed are not free. How do we read those?
See, you have to understand that there is something which is called PubMed and PubMed Central. There are two different things. Most of the articles which come across in PubMed Central are usually open access articles. Okay. So like IGO is a PubMed and PubMed Central indexed journal. Okay. So you will get free articles on those areas. Oman Journal is something like that. But there are a lot of articles which are not PubMed indexed, means which are not, free articles available on PubMed. So in those cases, you need to take the help of a librarian or someone who's got access to this. And this is where I feel that state societies, they should have a pool of journals which should be common journals, which is easily accessible to most of their members. Delhi Ophthalmic Society was doing that, where they gave open access to a few of those important journals which we want to see, read, and all. So something I feel most of the state societies also should be doing it as a part of their tenure. Okay, when they are in the thing.
This is something which KJO is trying to take up. So initially, IGO had such a platform, ONE network. So we are also, trying to bring the journal's full text to our members. We'll be doing something about it.
That's really great. That's really nice, ma'am, because sometimes reading also stimulates a person to write more. Okay,
right.
So when you are able to read an article and something you find something exciting and something which you have seen in your clinic almost in similar lines, you tend to write more. My only thought would be that I want all the members by at least, I don't know what should be the timeline, but at least 6 months down the line, Dr. Sanita should be telling me, okay, the number of case report submissions to Kerala Journal of Ophthalmology has actually doubled or tripled or even reached a maximum number, and I would be really happy, and that would probably determine the success or the failure of this talk. Okay, that is how I would look at it.
Hopefully, sir. Actually, it was a very inspiring presentation, sir. It was very practical, I would say. Like your approach to how to make a publishable case report, it was very excellent. I know I believe that we are going to get more case reports written in a good format after the
good
session.
Format. It should not be something where Dr. Sanita or the associate editor just rejects it on day one.
Yeah. And one more thing of concern which I would like to share in this group, because as you told, discussing a case in other discussion groups, it's very good. But sharing patient photographs for discussion in WhatsApp groups, which are professional groups, that is okay. How I don't know how is it being it can be misused, one thing, and also the consent of that particular surgeon to share that clinical material in that WhatsApp group. I think that has to be a check on that also.
Madam, we don't face these kind of issues with retina photographs, to be very frank. Okay, maybe with squint, definitely squint or external ocular adnexal cases, you may find these challenges. But what I would just suggest is that whoever is primarily sharing that photograph or in the group itself should take care that the identity of that particular patient is concealed. Okay, so that is something, it is on the primary doctors who's sharing in the WhatsApp group. It is his responsibility that he does not reveal the information of that patient, so that, see, you cannot control the sharing of the other members. That is something which is not in your control. So do that, and I think this, but we don't frankly see such challenges in retina photographs, because we usually, until then it's an OCT which tells the patient's name, but most of the times the crop format is available on the phone itself. That before you share, we try to do all those things and then send it across.
And regarding the case reports, I had a discussion earlier with Dr. Matthew Kurian. So he suggested that we have the Prisma and Strobe for other case. We do have something for case reports also. We have some guidelines and checklist. So one such is the CARE checklist, which was brought out in 2013. All these are available under Equator Network. So it would be a good practice to go into that while you go with a particular format of publication.
I sometimes I feel as an author or as a writer, okay, when a manuscript writer, when I'm writing, too many checklists, too many things actually deter an individual from writing. Okay, so there are times when I feel, okay, you have the care checklist. Okay, did you write the patient's information? Please tell the line number and the page number and the paragraph number. It's a headache. Who wants to do all those things? So I would suggest that, yes, for case reports, just be in the free flow, write what you think is the right thing. And that would be really this. But definitely for Strobe Prisma guidelines, that is something which cannot be compromised at all, because that's a format which needs to be followed for all your review articles. So you cannot miss. But sometimes the case reports, I feel that you should allow the author to express himself the way he wants, but within the journal guidelines. I'm not saying that the journal guidelines have to be relaxed, but that should be within the journal guidelines, but let him express the way he wants to express it.
Okay. Another thing was regarding the authorship of case reports. So we have restricted the number of authors to 4. So some other, and there was a very witty comment in some, I don't know, it doesn't take a village to write a case report, because you have to, number of authors is so much, so that there should be, it happens in institutions, a lot of people will be caring for that patient. So that is also something, before writing a case report, there should be a clear guideline who is going to be the first author, second author, third author, and the fourth author.
Yeah. Means, see, I always look at it in terms of authorship to a person is a motivation for that particular individual to write more or be a part of the research team or the research group, so that they contribute more and more towards the team and the organization and the institution. So sometimes, no, you have to give that motivation to an individual, okay, to be a part of the co-author. There is a lot of times when I tell my fellows, to be very frank, I'll be open to y'all and say that, write the case description for me and send it to me across. They would not have been the primary people who would have taken care for that patient. But sometimes, no, by giving that kind of, assigning some kind of work to that individual, it motivates him. Okay, if I write this, I can sit and correct that case description. But even if he puts in that effort to write that case description and sends it to me, he feels, oh, I am responsible for this case. I want to write it in the best format which my faculty would like to see. And that motivation actually makes him get involved in many more papers, many more reports. And that is how I think we should build up. I know that four authors is something which most of the journals like to do nowadays. I have seen that BMJ case reports are again still has a cutoff of 4 authors. You cannot go beyond 4 authors. But when you have state journals where you want to promote more people to write, I think you need to relax that number and keep it to 9 at least. That is where most of the international and national level journals, they do that. Okay, I think even IGO allows 9 for case reports. I'm not sure, but there was a time when IGO used to have 9 authors for case reports as well. So I'm not sure, man. It's totally, these are my thoughts. I told you these are totally personal, but it is just that I want people to get motivated enough. And that motivation sometimes comes just by giving them, being in charge of that particular case or that particular section of that case also. I think he or she deserves authorship in that.
I think I agree with Dr. Ramesh, because see, it doesn't matter how many authors you have. Actually, the academic credit goes to the first and the last author.
First and the corresponding, yeah.
Corresponding or the last author also, because the first author is the one who designed the study, writes up, takes responsibility, all those kind of thing, contributes the maximum. The final author is supposed to be the supervisor, the man who has coordinated everything and gives the final check and verdict of the thing. The rest of them are people who have helped and maybe co-fellows and things like that. So it doesn't matter the number of authors, the first and the last, that they get the academic credit and also the corresponding author. So you can choose to have 9 authors, let them be there. I mean, it's a credit for them to have a publication, right? And that motivates them, like Dr. Ramesh said, very, very nicely.
So there was a question in the chat, sir, how do we navigate authorship politics? So I think it's navigated.
There are criteria of who's done the maximum work, who's written the journal, the thing, who has designed the study, who has followed up and things like that. And then, of course, editing, critically evaluating, all those things. Even IJO has a authorship guideline. So I think based on that, we can avoid that kind of confusion and allocate who is going to be the corresponding author and things. Usually the corresponding author is a person who has actually done most of the work and he knows the case or the study in the entirety.
I think what Dr. Anina is asking is regarding the positioning of the authors, means the order in which the authors are mentioned. I'm not sure whether that is what she means, but politics happens in every field. Okay, but what I'm trying to say is the person who's the corresponding author, he is the person who's in charge of that manuscript, and he decides whom he wants in the team and at what order he wants to place in the team. It is totally his call.
If I may add a point over here, often the corresponding author is a junior person. And an institution, you may have a senior or HOD who says, not involved in any step, but at the end will want to be part of the publication process. And in a hierarchical system like that, it is not possible for the junior person to ignore that kind of a thing. So, yeah, authorship guidelines are there, but like you said in your presentation, real world scenarios sometimes trump the guidelines. Anyway, thanks for an excellent presentation. Happy to see you there.
Yeah, thank you, sir. Thank you so much.
If there are no other questions, I think, Dr. Biju, shall we wind up the session? What do you think?
Of course, it was a great talk, great discussion. Thank you so much, Dr. Santa, for curating this webinar. And thank you, Dr. Ramesh. We'll have a formal word of thanks from yourself.
Yeah, we have a formal vote of thanks from our editor, Dr. Monisha. Monisha, are you there?
Yes, ma'am, I'm there. I'm here.
Yeah. Hi, Monisha.
Okay. Yeah. So, esteemed senior faculty, dear KSOS members and colleagues, on behalf of the editorial board of Kerala Journal of Ophthalmology, I'd like to propose the vote of thanks for today's enriching session on how to write a case report. So this webinar is a part of the KGO Research Proficiency Initiative, which is conceived under the leadership of our editor, Dr. Sanita Satyan. We are deeply grateful to Dr. Ramesh Venkatesh for delivering such a structured, practical, and insightful session for this evening. The case reports are often the first step to publishing, and with your vast experience in academic publishing and research, you clearly and systematically outline the 10 rules and 6 essential components of writing a case report, making what seems often complex both approachable and achievable. So with your detailed explanation of case selection, manuscript structuring, the common pitfalls, it provided immense value to all of us. So on a personal note, I must say I have learned a great deal from the session. The clarity of thought process into case writing makes the entire approach more logical and easier to apply. So your guidance would certainly inspire many young ophthalmologists to take their first confident steps into scientific writing. I'd also like to sincerely thank Dr. Biju sir for efficiently moderating the session and facilitating the discussion with meaningful insights. My heartfelt thanks to the organizing team, KSOS, and all the participants who joined us online and made this session interactive. Academic excellence flourishes when mentorship meets opportunity, and today's session beautifully exemplified that spirit. So once again, I sincere thanks to Dr. Ramesh, Dr. Biju, and Dr. Sanita, and to everyone present. Thank you.
Thank you, Monisha. One more thing. This meeting will be shared in our KSOS YouTube channel. It will be accessible. And there will be more viewers, sir. And I'm sure that it was a very inspiring talk, and we'll have more case reports. And you're always welcome to give your case report to KJM.
Definitely. Thank you so much, ma'am. It was really a pleasure to be a part of such a meeting. This is the first time I'm probably presenting such a topic, okay, to be very frank. And I totally liked this experience which I had in making the presentation and in delivering this talk. Thank you so much.
Thank you. We'll close the meeting.